Hello to everybody. A very, very warm welcome to PHUSE April webinar Wednesday. Welcome across the globe. I'm proud to be today's webinar host for you. My name is Beate. I'm located in Germany, Europe, working for Mainanalytics and actually engaged in PHUSE at various places, what I very much enjoy. And personally, I do feel it's so good to at least be virtually connected, even though we can't really all meet face to face, even with those who are close by. But it's so great that we have the possibility to stay connected, at least virtually. Before we get started with the agenda, let me do some housekeeping. You were all put on mute, but please do raise any questions you might have through the chat window at any time. And at the end of the webinar, we will look into those questions and then hand them over to the relevant panelists. Furthermore, the webinar, this one, as well as all the other past ones, are recorded. So in case you missed it or you will, your colleagues are interested, so it's all available through the PHUSE website. So let's have a quick look at the agenda. I will provide you with a quick update from the Board of Directors. Then we will get the latest news from the planning for the EU Connect conference from the PHUSE EU Connect chair, Anne-Sophie Bekx. Then Chris Hurley, our PHUSE Americas director, will share insights on what the board is doing in terms of planning and installing and conducting the PHUSE single day events virtually, given the current situation. And then lastly, but not least, there will be a project update from one of the various working groups at PHUSE, and this will be given by Aimee, Basile and Mary Nilsson. They're going to talk about best practices for data collection instructions. So let's first have a look into the planning of conferences, and let's look ahead into 2021. 2021 US Connect conference is now getting back to Orlando, as this year's conference unfortunately had to be cancelled due to the situation at quite short notice. So I think that's really great news. Also, we have fixed the date already, so it's planned for March 7th to March the 10th. Then afterwards, the year after, in 2022, the US Connect is being held in Atlanta, and the place was already secured. And through all the communication channels, we will keep you posted on new information as it comes along. You might already have heard that the Computational Science Symposium for this year, which was originally scheduled for June, is now pushed out to September. We are planning now for the new dates from Monday the 21st to Wednesday the 23rd of September, going hopefully to be conducted at the Civic Center in Silver Spring as usual. And more information is shared through the usual communication channels, but also through all the working groups in due course, and so you will be on top of the information at any time. Anne-Sophie, as I said already, will provide us with kind of the actual news around the EU Connect conference planned to take place in Liverpool in November. So the board of directors is closely watching the situation and taking care of what's to be done. But in any case, the last chance to submit a paper is tomorrow. So we will have some kind of conference, that's for sure. Anne-Sophie will let us know more, but please do not miss the deadline of tomorrow to submit your abstract. Then at the current situation, PHUSE has taken a lot of effort also to go virtual, as this webinar, has been virtual all the time, but now also other events are now taking place virtually. And I think we're all getting kind of more used to the situation. And I think that's so nice to still have the opportunity to share knowledge and connect to our colleagues and friends. So we now have virtual SDEs. Next one is going to take place on May the 7th in Frenchtown, but there are also other webinars, and I'm going to talk about this StarDoc webinar on the same day in a minute. Then hopefully many of you already heard or are engaged with the PHUSE FDA Innovation Fridays. So the next ones are coming up on the 15th and 22nd of May, and this is quite interesting because it's collaboration with the FDA in looking into their burning topics. Of course, also there will be a webinar Wednesday again in May. There is more information to follow, and also we have an SDE in Bangalore on end of May. And the other months, Chris will let us know more in a minute. There is also news to be shared from other working groups. Very excitingly, there is now a white paper around a topic which affects us in everyday's work. So this white paper is addressing best practices for quality control and validation. That project had been conducted under the working group Standard Analysis and Code Sharing, and the white paper is available, and I think that's a great opportunity to have a look, maybe to also take this as a foundation for your company processes. So please feel invited to review and also share the information there. Then there will also be a multi-day meeting around data transparency. This is planned for beginning of June from the 3rd to the 5th. And it's also free for everybody to attend. And the agenda and registration is open. We have quite some very well-known presenters here. So check out for more information and get registered. And as I said already, there is the StarDocs webinar. This is around knowledge graphs, where Tim Williams, in collaboration with StarDoc, is going to present alongside with Guy Fosters on knowledge graphs and providing more insight. So also this is open for registration, and yeah, please do consider to get part of it. This was the quick update from the Board of Directors, and I'm now glad to hand over to Anne-Sophie, our EU Connect Chair 2020.
Thank you, Beate. So just a quick check. Can someone let me know if they can see my screen?
We can, and perfect. Thank you.
Great. Okay, so welcome everyone. So I will just give a brief update today on where we stand for the PHUSE EU Connect 2020 to be held in Liverpool. So my name is Anne-Sophie Bekx, and I will be the conference chair for the Connect 2020. So as Beate may have mentioned already, the call for papers closes tomorrow. So you have a bit more than 24 hours to get your abstract in, submit your abstract to hopefully be selected to present in Liverpool this year in November, from the 8th to the 11th is when the conference will be held. Now, we do realize that in these uncertain times, you may be reluctant to commit to anything because of travel restriction, personal safety, health reasons. But I would like to point you to a communication that went out from our FHUSE chairman of the board, Stephen Bamford, who together with the FHUSE board and the Connect committee are looking into alternative arrangements should the EU Connect not be held as a physical event. Of course, we will try to do everything we can to make it a physical event because it's great fun getting together, but FHUSE is investing in a state-of-the-art industry-leading virtual conference toolkit as part of a contingency plan so that it is possible for the event to go virtual if we see that companies are keeping travel restrictions, or if we just get a sense from the industry that people are not comfortable or don't feel safe traveling yet in November this year. In addition, there's a FHUSE blog post that was put on April 6th on why, even with all this uncertainty, we feel it's still a good idea to submit a paper and present at the FHUSE EU Connect. So with that in mind, I just want to encourage everyone to get in there, get us content so that we can set up the best FHUSE Connect yet, be it virtual or physical. Either way, there will be an event. Should anyone have any questions, please don't hesitate to reach out to me. I will do my best to answer them with the information I have available to me as we monitor the situation around the globe. So with that being said, I won't take up any more of your time. I will hand it over to Chris Hurley to talk about the FHUSE single day events, where we're sure they're already going virtual. Thank you.
Thanks, Anne-Sophie. I just want to double check that people can see my screen.
Yes.
I can.
Okay, I'm trying to go into presentation mode here. I think that's better, right?
Yeah, if you just change your display settings, please, Chris.
So how's that? Is that good?
That's good. Thank you.
Terrific, terrific. Okay, so thank you very much. My name is Chris Hurley. I am from MMS Holdings in Michigan, in Canton, Michigan. That's my day job as Associate Director of Data Sciences, but I volunteer as America's Director. And so I'm here to give you a little bit of an update on our single day events and some of the things we've learned as we've gone virtual. So these are extraordinary times for everybody, right? We're all working. You're probably all working from home. I'm working from home, everybody, right? The social distancing, the lack of networking, of getting with your peers, you know, it's a little bit troubling. You know, we're all working remotely, but FHUSE is working to provide our industry a community where we can interact during this global emergency. And so we are taking steps to produce the greatest and the best events we can possibly give you. And so with that being said, I'd like to talk to you a little bit about the single day events leading up to this year, and then some amazing numbers that we've seen this year. So I'll take us through a little tour of some analytics that we developed here for this webinar. And we'll take a look at the virtual single day events. We're planning the virtual single day events through second quarter this year, so all the way through June 30th. If the country doesn't get back online, we may have to revisit that decision and continue with virtual events. But for now, let's just see how we're doing. So if you've attended a single day event, you've probably seen this slide. It's a static slide, you know, shows some good numbers here. But at this point, I want to pop out to some analytics that we developed here. And let's see if I can, Wendy, are you able to see this on my screen?
We do, Chris.
Excellent. Okay, good. So back in the beginning, in 2008, FHUSE had our first single day events, and we had 3 events. And we had a couple in the United Kingdom, and then we had one in Switzerland. And through the years, we slowly expanded. We got into Germany. Then here in 2010 was our first ever event in the United States. We had 112 people. Now these are all, your typical networking events. Come look at the great presentations, all these great live events. And as we progress through the years, we see more and more locations. PHUSE is going global. And then in 2013, we had our first event in India. And you can see really good numbers here, 227 in India. And as we go forward in time, you can see the spread and the reach across the map. In 2018, we had our very first event in Canada, and that was great. Thank you, Canada. We had another event there subsequently in the next year. And so we've had great events, global events, and they've been outstanding. Excuse me. So now let's look at some numbers. Let me straighten this out a little bit. So in 2008, we had 147 attendees with an average of 49. We had a membership base of 386. That's where we started in 2008. And as we go forward, we can see more countries, more membership. 2010, we get to our first US event, and the numbers continue to climb. And what we started seeing as we received had more events, we saw India kind of overtake everybody in the number of attendees at these single day events. So as we go through the years, we kind of bounce back and forth between the US and India events as having the most number of attendees. Now let me skip forward to what we saw in 2020. So we had to go virtual, and during the first two events of 2020, we had an average attendee count of 326. So we had 302 members attend our US event, our very first US event, the Springhouse event. And then the Pune event had just last weekend had 351 attendees. So from going from an average of say 80 to 100 attendees per event, all of a sudden, because we're virtual, there's no traffic to consider. There's no, travel. More people can volunteer their time, can join, can present, and these really opened up. So these numbers are just fantastic. So we've pretty much tripled the amount of people that can attend these events. So just really fantastic. And I just want to thank everybody. If you've attended a virtual single day event, thank you for attending, and especially if you, for the co-chairs that have developed this, this first event that we had in Springhouse at Hientzsch, this was it was different. And so, we're learning and we're making these events better, and it's going really well so far. Okay, so let me skip back to my presentation. And let's see if I can get this thing going. So many more attendees can attend our virtual single day events. The content, as always, has been excellent. Our co-chairs do an outstanding job recruiting the best speakers. The technology that we've had, now we've had so many people come into these webinars and great numbers, and everything's been working well. And technology at home, I know here, I got dropped off of a webinar because we had so many people in the neighborhood using using the internet, and then the internet at my home got dropped. So, but technology's been good. Attendee feedback is crucial in order for us to continue to improve the virtual experience. So as you attend these events, maybe this webinar, any of the single day events, when the feedback is requested, please give that feedback. Let us know what you think. You know, every idea is a good idea. Let's try, let's try to make these the best events ever. One more thing about the PHUSE app. Utilize the PHUSE app because it has, when you attend these virtually, you can look to see the people that are at that event virtually. You can look in and you can do some networking and see your friends online. So use the PHUSE app. It has good information. It's really well done. So the schedule of events is on the website. The next event is Frenchtown. It's on May 7th. The co-chairs have done an outstanding job getting you the best speakers. They're talking about data anomaly detection with visualizations. So it's going to be a very interesting event. So I hope to see you there, and I hope to see you online at future events as well. Okay, so at this point, I'd like to turn it back over to Aimee Basile from Surface Oncology and Mary Nilsson from Lilly. They're going to give you guys a working group update on best practices for data collection instructions. So Wendy, if you could pass that ball over to them, that'd be great. Thank you.
All right, I think I'm showing my screen.
Yep,
Is that
loud and
working,
clear.
Wendy? Okay, great.
It is.
All right, so thanks for joining everyone today. Mary and I are going to present findings from our best practices for data collection instructions project. Just as an overview, we recently conducted a survey to evaluate different industry approaches to collecting AE data and how those data are evaluated for treatment emergence. This came about because the Analysis and Display White Papers project had done a paper on the analysis and displays associated with adverse events. And in that paper, they found that variations in the collection methods and definitions of adverse events could impact the standard analysis and displays. And so they basically asked my group, the best practices for data collection instructions, to see if we could come up with standard data collection instructions that could support their analysis and displays. The history behind this is that the group, the best practices in data collection instructions group, kind of, I guess we kind of, faltered a little bit. We kind of went around in circles and then tried a bunch of different things to try to come up with some recommendations. And then when I joined the group, I think my primary question was, are we really that disparate in the way that we're doing things? There were a lot of anecdotal evidence that, things might be different. And so, we did find, one example, Dr. Pulpit in the FDA said that she found 329 ways to represent, and this is just one example of AE causality. And that was in standardized data that she was reviewing. So that was one example. And then obviously in the white paper, they asked about, is there consistency? And these were questions they were posing. Is there consistency about when events start after informed consent, but before the first dose? Are those considered AEs always? Events that start before the first dose and worsen after treatment, is that being collected or documented always? What if events improve after first dose? Is that being collected? And then serious events that occur after study completion. So I kind of wanted to find out more. So as a group, we decided that we would actually conduct a survey to find out if we're really doing things that differently. So we developed a two-part survey, and the reason there were two parts is the first was specifically around how the data collection practices around AEs. And then the second part was more around the treatment emergence definitions. And that was obviously to give the analysis and displays white papers project group some more information as well. So because we had this kind of a two-part survey with two different focuses, we did realize, and we did suggest that the respondents may need more than one expert to complete both sections, that we didn't feel like one person in most organizations had all of that information. We did ask that this be phase 2 through 3, only 2 or 3, because we felt like phase 1s and phase 4s do present their own differences in terms of, kinds of data that you are looking for. So we thought, let's kind of try to limit the complications by looking for something, or looking at studies that are only phase 2 or 3. And along those lines, again, we asked the respondents to complete this survey based on one study or therapeutic area, again, trying not to complicate things, where we understand that a lot of companies or sponsors will do different things in different ways depending on the indication or study type. So again, if they kind of had one study in mind while they answer the survey, and then maybe if there was another way they did things, they could answer the survey again for that particular study. So that is kind of, those were the instructions that were given. Now, so the impact, or in other words, what actually happened was not maybe exactly what we intended or asked for. So we did have 42 respondents, we know that. However, due to privacy concerns, we did not ask people, the respondents, for a company name. And so we don't actually know if those 42 respondents are different. As I said, they may have come back per our instructions and filled out the survey again under a different, for a different study, but they were the same company. We don't know, if they were sponsors or CROs. So kind of an interesting, unknown variable there. Also, the dual focus, as I mentioned, the 2-part of the survey meant that we actually ended up with more responses in the first section, in the data collection section, and fewer responses in the treatment emergent section. And I do believe that, as we mentioned, that's because maybe the people responsible for data collection in a sponsor or company would fill out the first section and not really be able to answer the second section, and either didn't have time or resources available to fill in the second part. And also, just to the treatment emergent section that we did ask about was pretty simplified. It wasn't, it could be very complex the way treatment emergence is defined. And so we didn't ask about changes in seriousness or causality. We only asked about changes in severity. And we actually used, I'm trying to remember, I think we used, Mary, you can correct me if I'm wrong, but I'm pretty sure we used numerical, like toxicity grade. I don't think we used mild, moderate, severe. I think it was numbers. And we didn't include complex study designs. They were pretty straightforward. So that may have also influenced some of the responses. Okay. Trying to move forward. There we go. Okay, so with all that in mind on how we conducted the survey, here are some of the results that we came up with, that we found. So one of the questions was, when do you start collecting adverse events in your clinical database? So obviously we understood that there's a difference sometimes between your clinical database and your safety database. So we were just asking specifically for the clinical database. You can see that the majority of respondents did say at the time of informed consent. There were some who collected SAEs at informed consent, but only non-serious AEs at the first dose. So that was a slight nuance, but there was definitely a majority at informed consent. Similarly, we asked, when do you stop collecting adverse events in the clinical database? And so we said, you know, most people found or responded that they do that at the protocol specified safety follow-up visit. So we didn't want to get too detailed about when that safety follow-up is, whether it's 30 days or 2 weeks or however long that is. But as long as we felt like as long as it was specified in the protocol for whatever that period is for that intervention, then we felt like that was good enough. Obviously, there can be times when you continue to follow at the you know, after that safety follow-up visit, which was kind of what a lot of these others were, and some didn't even have, maybe they didn't even have a safety follow-up, or they just stopped collecting at the last dose. Okay, so are people recording serious adverse events after the subject ends study participation? And again, this is in the clinical database. So again, in the safety database, we understand SAEs must be recorded, you know, pretty much always. But are you recording them in the safety or in the clinical database after the subject ends the study participation? The majority, again, here said no. There were a few that said yes, and even with the yeses, a lot of them said that if the database is still open and the site puts it in there, they would allow it, but they wouldn't, you know, they wouldn't query to have them remove it. But they weren't necessarily asking for them to be entered. It was just if the site felt like they wanted to enter that SAE, then they could. And this in question was, when would you record a new adverse event record? So the example is that you have an adverse event that started and something changes on that adverse event. Would you start a new record for an adverse event, or would you, some sponsors might just update data within that same record, which, as you can see at the bottom, is do not create an additional record. So there were a few there. So there can be multiple responses, so you could kind of check all that apply. You can see that most sponsors or respondents are creating a new record whenever there's an increase in severity or toxicity grade, and also if a worsening of a medical history event. So you would actually have a medical history event in the medical history form or data set, and then you'd also have an AE record when a medical history event worsens. Other high responses were changing from serious to non-serious to serious. You'd have a new record for that, but less so changing from serious to non-serious. So this gets to the question that Mary's group asked, which was improvements. So you can see that there is a less respondents are creating new records, or tracking, I should say, decreases in severity and toxicity grade and changes from serious to non-serious. So improvements in AEs, they are not necessarily recording that in a you know, in a way that is recorded in a separate record. So that is interesting finding. And even fewer, you can see, are tracking changes in action taken, and then even each start and stop of an intermittent AE. And then the other question, another question we asked on collection was medical history versus adverse event form. So which situation would you consider medical history versus adverse event? So an event that starts after informed consent and ends before the first dose, the majority would count that as an AE, which supports our first question, which was, when do you start collecting AEs, which is after informed consent. An event that starts after informed consent and ends after the first dose is also an AE, again, supporting our first two questions, the start and the end. And then the event starts before informed consent and ends after first dose, most people would consider that medical history. So again, I think that's consistent with what our other questions found. So now the next couple slides are going to talk about treatment emergent definitions. So this would be the second half of our survey. I'm going to let Mary talk about these two slides. Mary,
All
are you
right,
on?
thank you.
Okay.
I am.
Great.
Haven't been kicked out. So yeah, so just before we get into the details of these slides, I'll just reemphasize and acknowledge that we did have fewer respondents on this section, as Aimee mentioned. The other problem with treatment emergence is that unless you really dig deep in somebody's code, it might be hard to know whether they consider it treatment emergent or not. So it's quite possible in some of these places where we say, this is how many respondents would consider this treatment emergent. This is how many respondents that would consider it not. We're just doing the best we can on trying to figure that out given the responses to the surveys, but it's possible these aren't quite right if someone were to dig deep in that company's code. And so maybe the people who responded are also just saying what they think, but until you dig deep in code, we may not know for sure. We did consider interviews instead of just answering a survey, and for some of this treatment emergent type questions, we might choose to do some more interviewing and really dig a little deeper on what people might be doing out there in the industry, or we may not do that if we don't think that's value added. But anyway, just a caveat that it's not like we know for sure that this is what these respondents would be doing at at the end, but this is our best determination given the answers we got on the survey. So we organized these with various scenarios. So the first one is an event didn't occur at all between informed consent and first dose, but the event started during treatment. We didn't really have a survey to look at this. I think we could say that, hopefully goes without saying, that everybody would consider this treatment emergent. This isn't our area of variation. That one we know everybody's going to consider treatment emergent. And similarly, if the event started between informed consent and first dose, continued into treatment, and eventually the severity increased, right? So this one, we did have a survey to check this, but to no surprise, this is another case where we didn't expect variation, and we don't see any evidence that there's variation on this one. So events that start and events that worsen during treatment, we have a lot of consistency. So the areas where we were looking into whether we had inconsistency is certainly at a whole different level of complexity and detail. So we have so I'm now kind of on the fourth row. So events started between informed consent and first dose, continued into treatment, and shortly after the severity decreased, right? So this is one where we're suspicious that the people doing the treatment emergent logic and the collection instructions, it's possible that there's not a great understanding between those two things, or maybe some of this is on purpose, or some of this might be just because the collection instructions people and the treatment emergent definition people aren't always talking to each other. But we do think it's not uncommon, right, that the instructions are going to say, I want to know if a severity decrease, and the best way for me to know that is by entering it as a new adverse event, indicating the lower severity. And then your treatment emergent people might have very simple logic that says, if the start date is during treatment, it is treatment emergent, right? So in that combination of things, this scenario then could be considered treatment emergent. And from the best we can tell from the survey result is we do have some respondents who would consider this scenario treatment emergent with, and then a little bit more that would not consider it treatment emergent. The next scenario event started and stopped between informed consent, and that it came back during treatment with the same severity. This is one area that we were curious about and how much variation we had. And we do have a little bit, so the majority would consider that treatment emergent, but we do have some that would not. Okay. Next slide.
All right.
All right, then the event started and stopped between informed consent, and the event came back during treatment with a lower severity, right? So this is another interesting one. We're like curious, in the end, what are people doing? And the vast majority will consider this treatment emergent, probably because it, it went away, came back. Their logic is start date during treatment, and if so, then it's treatment emergent, right? So the vast majority would consider this treatment emergent, and some would not. A couple would not. Then we get into even more, tricky things. So you can have an event that started in informed consent, decreased in severity before the first dose, but then increased back to the original severity during treatment. And it didn't stop, right? So there's these subtleties on whether the event stops or doesn't stop on logic. So this is an event that didn't stop. The severity is just kind of going up and down. This is a scenario that was relatively split. So we had some with treatment emergent, some not. And similarly, it's, now we're getting into, when do people, how long do people consider treatment emergent past dose? Like, so we tried to say like, relatively close, like approximately 20 days. And let's say it, came back at the same severity. So it occurred during before treatment, it continued into treatment, went away, came back. This is also very split on what people do with this. And a lot of respondents will say, well, a lot of this is going to depend on the protocol, that how far you go past dose will depend on the protocol. And then we have other splits on, again, how long or much further. A lot of, when you start including events post-study drug, there is a lot of variability. And this is one thing that we did address in the analysis and display adverse event white paper. We did give some guiding principles on some of these things of, when do you go past last dose? And one of the big things that we said in that paper is it also depends on your study design. So if you have a treatment period followed by an open label period, right? Adding days past the treatment period gets a little bit more complex. And that was a little out of scope of this particular survey. That would just get into too tricky of things. But the main thing is this certainly provided evidence of we do have areas of variability on how treatment emergent is defined, especially when you get into these, events that go away and come back, and changes in severity that bounce around. We do have a lot of variability. Of course, with the caveat with, not a ton of respondents, and it's also unclear, if necessarily this would reflect if you dig deep in their code, but this does actually indicate, and we kind of suspected that we had some variability with some of these nuances.
Yeah, and I think, as Mary has kind of indicated, that it's difficult to survey this kind of thing, and we have talked about doing some more, something more in depth, like an interview around these kinds of questions. So, so that actually gets me to kind of our conclusions. We did find that in the data collection and the treatment emergent definition, but definitely in the data collection, we found some consistency, but we also found some variation. So I think in the data collection, there was more of a consistency there. And also, as Mary pointed out, in the treatment emergence definitions, there were some areas where the variation in AE data collection did affect treatment emergent definition, but also protocol definitions have an effect as well. So I think when we look at things, when we go to make our recommendations, that we're gonna have to look at both of those things, the data collection and the protocol definitions. other thoughts that we had as we were looking at the data and thinking about some other things that could have impacts or be impacted by data collection and treatment emergence definitions. But one is the impact on the site. So all this variation in data collection actually places additional burden on the sites because they don't necessarily understand each sponsor's requirements. Even if we have, as everyone knows, CCGs, there's still some of the CC completion guidelines are not always this detailed. And some sites just kind of have to make assumptions based on their understanding. And they probably don't even really understand exactly what this data, may not understand the treatment emergence, determinations that we're trying to do, and not to say that if they understood that, they might make different decisions, but, that's something that, you have to think about the connection between data collection and treatment emergence definitions. We thought about how CDASH is approaching this problem as well. And we did look, the implementation guide does have CRF completion instructions, but they are not nearly as detailed as these collection practices that we surveyed. So they don't talk about when to collect adverse event data or when to create a new record or anything like that. It's just more things like dates and collecting things like signs and symptoms versus diagnoses versus signs and symptoms. So I think one of the things we're going to look into is CDASH an area where some of these questions can be answered. So we definitely feel like there is a space here where we need to further harmonize collection instructions and the treatment emergence definitions. So we felt definitely we have support. The survey itself supported our next steps, which is we will create a white paper detailing these results and exploring some of our other thoughts. So the slide I just presented. So we will probably explore more about the CDASH and other approaches for how we could harmonize these data collection practices. So we are working on that, and we hope to have that released by the third quarter of this year. And then based on that, we do want to have the best practices paper released next year. So we will build upon the survey results, any interviews that we do, some of the exploration that we'll do in this white paper for this year, and come out with what we think are the best practices next year. So that is the plan. And then this is just our contact information should you have further questions. Okay.
Thank you so much. Thank you so much, Aimee and Mary, for this comprehensive insight into your project. Thanks for all the work you're doing. Also to everybody else on the call, or maybe in your teams who is contributing to those FUSE projects. A big thank you. I think that cannot be repeated often enough. But also from the presentation from Aimee and Mary, we could hear that how exciting our jobs are. It's so many different aspects and details we have to tackle along our days. So I think we are really quite lucky in our jobs. And I also want to thank the other presenters, Anne-Sophie and Chris. And also want to thank Wendy for taking us through this webinar and helping us with all the technique in the behind the scenes and also in the preparation. I actually don't see any questions. Or Wendy, am I overseeing anything?
No questions, so we're good to go. Good to close out.
Okay, so then I would thank everybody again, and thank for everybody on the lines anywhere in the world. Thanks for attending. Stay safe, take care, and I hope to be in touch, at least virtually, with many of you very soon. Thank you. Bye-bye.
Thank you.
Thanks. Bye-bye.
Thank you. Bye.